Good afternoon, everyone. Welcome to our webinar, Strong Hearts, Strong Women, Navigating Cardiovascular Wellness. My name is Tony Brantley, and I'm a program coordinator with the Community Health and Wellness team at Suburban Hospital located in Bethesda, Maryland. We're thrilled to have you with us today for this important discussion. Throughout the presentation, we encourage you to submit any questions for our guest speaker using the Q&A box at the bottom of your screen. At the conclusion of the webinar, a short evaluation will appear. We will greatly appreciate your honest feedback as this helps improve future programming. Please note that today's webinar is being recorded, and a link to the recording will be shared in the coming days. Again, thank you all for being here. It is now my pleasure and honor to introduce our guest speaker, Dr. Lily Baruch. Dr. Baruch is an associate professor of medicine in the Division of Cardiology, Department of Medicine, and a member of the Advanced Heart Failure and Cardiac Transplantation Group at Johns Hopkins Hospital. Dr. Baruch received her undergraduate degree from Harvard University in 1992 and her medical degree from Johns Hopkins in 1996. She continued at Johns Hopkins for residency training in internal medicine, completed in 1999, and fellowship in cardiovascular disease and advanced heart failure transplant, completed in 2003. Dr. Baruch is the founder and director of the Sports Cardiology Program, which offers expert cardiac care specifically geared towards athletes of all abilities. She has expertise in the outpatient management of advanced heart failure and many types of cardiomyopathies. Dr. Baruch also has a longstanding interest in women's cardiovascular health, particularly in how some cardiac conditions affect women differently or present with distinctive symptoms. She is the medical director of the Columbia Heart Failure Clinic and the Howard County director of the Women's Cardiovascular Health Center. Dr. Baruch believes that educating people about heart disease, medications, and lifestyle changes, including healthy eating habits and regular exercise, is critically important in helping her patients understand how to achieve and maintain wellness and feel in control of their cardiovascular health. She is an avid runner and triathlete herself, competing in several triathlons and other races per year, as well as the occasional marathon. Without further ado, I am honored to present Dr. Lily Baruch.
Thank you very much, Tony, and it's an honor to be able to speak to you today, and I'm excited to share what I know about this topic, which I think is very important and near and dear to all of our hearts. Right, are the slides showing up well here?
Yes.
Great, thank you. All right, so I wanted to speak to you all today about strong hearts, strong women, navigating cardiovascular wellness. Over the next 45 minutes or so, I want to explain to you the main changes that occur in normal cardiovascular aging and to talk about some age-related changes that are specific to women versus men. And I'm hoping that you'll all be able to understand some of the sex differences that we see in cardiovascular disease and a little bit about successful cardiac aging. Cardiovascular disease is the underlying cause of death in 1 out of every 3 deaths in the United States. And it really causes an average of 1 death every 37 seconds. So that's pretty astonishing when you think about it. That's about 1 death per minute in women. And cardiovascular disease claims as many lives every year as cancer, lung disease, accidents, and diabetes all put together. Just a brief primer on how the heart works. So many of you may already know this, but a lot of people don't. And so I just wanted to say briefly, the heart is a pretty amazing pump in which blood returns on the blue side from the body to be pumped from the right side of the heart into the lungs. And then it gets oxygen from the lungs, returns back to the left side of the heart, and is pumped out to the body from there. A lot of people think that the right side of the heart pumps to the right side and the left side pumps to the left side, but that's not quite how it works. The right side pumps to the lungs, and the left side pumps to the rest of the body. Normal cardiovascular aging includes a lot of changes that are age-related that, we probably all wish we didn't have to be subjected to those, but unfortunately we all do. But there are changes both in the larger heart structure and the microscopic structure with age. There's a stiffness in the blood vessels that is normal, that often goes with high blood pressure. And together with all of those is an increasing risk of heart attack and stroke that is part of normal aging. Some of the structural changes that we see, including the deposit of some small amounts of fat on the outside of the heart, some thickening or hardening of the heart valves, enlargement of the top chambers of the heart. You can see that here in the section labeled B, and increasing thickness of the heart muscle walls here. Some of the microscopic changes, ones that you could see only under a microscope but wouldn't be able to see with the naked eye, include a reduced number of heart muscle cells, increase in the size of the cells that are left, some fibroblasts, which make small amounts of scar tissue or fibrosis. These changes also occur in blood vessels that include something called vascular stiffness. And that's a normal part of aging that increases the stiffness in the arteries and the smoothness of the blood vessel walls. And those are some of the reasons why an increase in cardiovascular disease happens with all aging, even if it's normal. Some other types of diseases can accelerate that process, such as kidney disease and other things that can cause the vascular stiffness to increase more rapidly as well. Together with that, high blood pressure is extremely common as we get older, and the vascular stiffness is part of what contributes to that, among other factors. So this gentleman here is saying something about my blood pressure is 180/90, which if you reduce that mathematically, that's 2/1. So that doesn't seem so bad, right? Of course, that's too high. And our goal is to keep blood pressure down to reduce cardiovascular risk. The coronary arteries also are subject to aging. The coronary arteries are small arteries that feed the heart muscle itself. So they come off the aorta, the main blood vessel that comes out of the heart to feed the entire body. The first branches off the aorta are the coronary arteries, and there are 3 of them that supply oxygen and blood to the heart muscle itself so it can continue to function. When something goes wrong with one of these coronary arteries, that's what happens. That's what causes a heart attack. So cholesterol and plaque can build up in the arteries that can block blood flow, and they're therefore also blocking oxygen to a section of the heart, which leads to a heart attack. So in the square insert here, you can see the area that's marked in purple is the area that might be damaged from a heart attack that is occurring where the little circle is shown there. So nearly 800,000 Americans will have a new heart attack in the next year, and about 500,000 will have like a second heart attack, and including some silent heart attacks. The average age for a heart attack is actually not that elderly. Average age for a heart attack is 64 in men and 70 in women. So I think that's something that's very important to realize. This is not just something that happens to people that are elderly. Notice also that the average age for heart attack is somewhat higher in women than in men, but the overall risk of having cardiac disease in women and men is the same. It just tends to happen in women a little bit later. Some changes that are specific to women can include factors related to estrogen and other female hormones, some differences in symptoms that can happen in women of a heart attack or angina, which is another name for cardiac chest pain, and an increase in heart muscle stiffness at a younger age than in men. There are some obvious physical differences between women and men overall. So there are hormonal differences, age and size differences, and other factors, and differences in biology. Women are not just slightly smaller men. There are a lot of other differences that we have compared to men that need to be accounted for in terms of health and medical issues. There also are societal differences, patients relating to patient factors themselves, and also factors relating to how you interact with your doctor. So heart health for women is very important. And like I said a minute ago, women are not just slightly smaller men. There's some specific considerations for women, both in how women tend to present with heart disease and how to take care of women in the best way possible. This male doctor here is saying to his patient, many women are more at ease with a female doctor, and that's why I'm wearing a wig. Well, I don't think that's necessarily a good solution. But some women feel more comfortable with female doctors, and others don't mind or may prefer a male doctor, and that's okay. It's important for you to have a doctor that you feel comfortable with, that you trust with your health care, whether that be a male or female doctor. One thing that's very important is that women who are having a heart attack may have different signs from men. The classic signs of heart attack or symptoms, warning signs, were called that, but are primarily a description of how men experience heart attacks. Some women as well, but not as regularly. So the classic signs of heart attack include things like uncomfortable pressure, fullness, pain, or squeezing in the center of the chest that either stays with you or goes away and then comes back repeatedly. Sometimes it spreads to the neck or shoulders or arms, can include feelings of nausea, shortness of breath, sweating, or fainting as well. So this is kind of the classic description, but women have more variety of symptoms, which were previously called atypical, but I like to say there's more of a variety because they're only atypical if it's not you, right? So other types of chest pain, sometimes just stomach or abdominal pain, nausea without chest pain is fairly common, shortness of breath or difficulty breathing either with or without chest pain, or other severe symptoms such as cold sweats, paleness, palpitations, feeling like you might pass out, or even just back pain can sometimes signal a heart attack in women. Men get atypical symptoms too, but less commonly than in women. Other differences between women and men, there's something that's now called INOCA, which stands for ischemia with non-obstructive coronary artery disease. That means signs of either an impending heart attack or of cardiac chest pain. But when you actually look at the coronary arteries, there aren't any major blockages. It used to be thought that this wasn't really a serious condition, but it turns out that it also is. This is much more common in women than in men. In chest pain is more likely to be labeled as atypical or non-cardiac, but a pretty high percentage of these women actually ended up with cardiac events. So we now know that this may be due to microvascular obstruction, blockages in the microscopic arteries that we can't see, or soft cholesterol plaque, not necessarily hardened plaque, or spasm of the blood vessels. There's several different ways that this can happen, but it's an important condition that we as doctors need to recognize, that some women may have cardiac symptoms, even if the coronary arteries don't appear that damaged when we look at them. Women have a lower rate of, now this is onto a different topic, where differences between women and men in terms of heart rhythm status. So atrial fibrillation, some of you may have heard of that or may even have it yourselves, is an irregular type of heart rhythm that increases the risk of stroke. Women have atrial fibrillation somewhat less commonly than men, but in women who have it, they actually have a higher risk of stroke, even with the same risk factors. So these are important considerations if you have atrial fibrillation to make sure your risk is assessed accurately. The American Heart Association actually recommends including sex as an additional risk factor for stroke when we determine the risk of someone who has atrial fibrillation. Women are also less likely to be referred for procedures to get rid of atrial fibrillation due to either underlying medical factors or perhaps societal or bias factors that we may or may not be aware of. So that's something that definitely needs to be studied. Another big thing that happens to women and not men, of course, is menopause. So there's a change in the way that blood vessels age across the menopause transition. So before menopause, we're protected by estrogen and other female hormones. And throughout the menopause transition, over that several year period, there's a significant change both in vascular stiffness and overall cardiac risk. So we believe that one of the ways that menopause leads to increased risk of heart disease and stroke is because of increased stiffness of the blood vessels. So what do we do about all this? The key to successful aging for everyone, regardless of your risk factors, regardless of your sex, is also the following three things, right? There's no magic bullet here. So what we want to do is to minimize all of your cardiovascular risk factors, and we'll talk about that in a minute. Exercise and maintaining good fitness levels, healthy diet, and other healthy lifestyle choices. So these cartoons here in the bottom are working out, eating healthier, and of course, not smoking. So when we think about heart disease risk factors, we think about non-modifiable risk factors and modifiable risk factors. Non-modifiable are the things that you can't do anything about. Your age, your gender, your family history, or genetic background. Those are things that can't be changed. But most of the additional cardiac risk factors that exist are modifiable, whether or not you smoke, blood pressure, high cholesterol, being a sedentary person, obesity, diabetes, and also including stress and inflammation. That's not to say that these can be eliminated, but if you have some or many of these risk factors, we should work to get them under as good control as possible to lower the risk. Things that you can do to reduce your risk factors or to stop smoking if you smoke, improve your diet, regular physical activity, stress management. Of course, we all have some stress, but to the extent that that's possible, and medications to control the medical problems that are in the middle column to help reduce the risk there as well. So this gentleman here goes to see his doctor, and the doctor says, well, it doesn't look like you've been taking your cholesterol medication, have you? Let's talk for a minute about healthy eating habits. So eating right is very important, and whether or not you need medications for your risk factors or whether or not you are battling other medical problems, having a healthy diet is extremely important for everybody. There are many dietary factors, and I'm not going to go over every line on here, but just to mention that there is strong evidence for eating an overall healthy diet. From a cardiac standpoint, you may have heard the Mediterranean diet as sort of like the model diet of things that we recommend. That doesn't mean you have to only eat at the Mediterranean restaurants, but it generally includes a healthy balance of lean protein, vegetables, whole grains, fruits and nuts, and things like that. There's a high amount of evidence that shows that this improves blood vessel function and reduces stiffness. Higher fruits and vegetable intakes also improve vascular function and lower cardiac risk. We recommend fish, especially fish that are not too high in mercury. Those are kind of the healthy options. Things that are less healthy are eating high fat diets, processed foods, things like that, that we generally try to avoid, fried foods, and so on. For the fats that you do eat in your diet, we try to stick with unsaturated fats, things like olive oil. Most people have heard about that. Oils that come from nuts, and to try to stay away from fat that comes from animal sources, such as red meat, fried foods, and greasy things like that. Generally recommended to reduce sodium. If you have high blood pressure, you need to reduce it more, but average American diet is too high in sodium kind of across the board. And there's some other sort of miscellaneous things that can affect blood vessel function that can also be beneficial. This is just a summary of these things that we were just going over. We try to reduce saturated fat and cholesterol in the diet, generally limiting alcohol to no more than 1 drink per day or less, especially with recent data that came out showing that higher levels of alcohol are associated with increased risk of a number of different medical conditions. Avoiding trans fats and saturated fats as much as possible as well. We know that better fitness also leads to more successful aging, and that all of these factors here, such as increased percent of body fat, calorie overload, sedentary lifestyle, high blood sugar, and muscle weakness, can lead to worsening or more establishment of chronic diseases. So we'll talk about exercise for a minute. This is a very outstanding example of successful aging. This woman, Ernestine Shepard, started becoming a bodybuilder, I think, in around age 70, and this is her at age 80. I think that we should all be able to look this healthy at any age, much less age of 80. So I think that's an amazing example of what healthy diet and healthy lifestyle can do. But you don't have to become a bodybuilder or an Olympic runner or something like that to be able to be healthy. One of the emphasized points from the American Heart Association is that we can live longer by sitting less. We tend to sit a lot, and there are many reasons why sitting for long periods of time without moving around is not particularly healthy. The American Heart Association, as well as other World Health Organization and American College of Cardiology, all recommend at least 150 minutes of at least moderate intensity exercise per week. Now, moderate intensity could be brisk walking, it could be stationary bicycle. It can also be more vigorous exercise if that's something that you're able to do and are interested in. But it should be some kind of exercise. 150 minutes per week is 2.5 hours total. And that can be spread out throughout the week, however you're able to. So most people would recommend that way they would do 30 minutes per day, 5 days per week, or something like that. One thing that's not on this slide, but the American Heart Association now also recommends at least 2 days of strength training as part of that exercise, not just aerobic exercise. And that's important not just for cardiac risk, but also to help improve balance, reduce fall risk, and reduce risk of osteoporosis. If this amount of exercise is either out of your wheelhouse or it just seems unrealistic, please know that something is always better than nothing, and that even 5 or 10 minutes per day of vigorous exercise or 15 minutes at a time of less intense exercise like walking still has significant benefits for your health. And more than that, of course, is better. More than 4 to 6 hours per week, there's not much additional benefit beyond that, but so people who really enjoy being outdoors for longer periods of time can certainly still do that. But somewhere in this range is a good amount of physical activity. In general, we want to just have people moving so that if you can get up and move around more frequently, even if you're just walking around inside, or now the weather is finally beautiful, we can walk around outside. But we know that long periods of sitting are associated with higher risk of mortality. And for every hour of sitting more than 7 hours per day, there's an increase in cardiac risk. So while we're talking about exercise, we talked already about the minimum recommendations, but that additional exercise above that is still of benefit. One of my interests over the years has been sports cardiology. And even though I wear several hats at Johns Hopkins, this program that we have has really taken off with a high amount of interest, not just for high level athletes, but any highly active adults. But these principles of athleticism and being physically active apply to everybody. So our sports cardiology program at Hopkins serves highly active individuals at all levels of sports. So I see college athletes, some elite athletes, but a lot more recreational endurance athletes. Masters athletes counts as everyone over age 40, which includes myself, and everything in between. So this is not just sort of, people playing college lacrosse or whatever. We see a lot of people that are very active, people of an entire age range. I have many athletes in their 70s and 80s that are still very active and also very healthy. A few people want to know, well, what is sports cardiology? How is that different from regular cardiology? And the difference is the type of patients that we see, not just in the activities that they do, but in the way they think about their fitness. So we evaluate people who have symptoms, of course. People who have established cardiac disease, many of them are able to stay athletic or become athletic after they've had a heart attack, something like that, have decided to turn their lifestyle around into becoming healthier and become very active. Also, sometimes people come to be evaluated before they start a sport, or they're about to start a new sport, or they want to increase their level of fitness, and they may come for sort of a pre-participation evaluation as well. In people who are very high-level athletes who are exercising vigorously for many hours per week, there can be some cardiac changes. Just the way muscles get bigger when you lift weights, your heart changes when there's a high amount of exercise. And we help evaluate some of those changes that might be mistaken for an abnormality by someone who's not used to seeing athletes. So as with anyone else, some of the common types of symptoms people come in with who are athletes are the same as anyone would come to a cardiologist, such as chest pain, syncope means passing out, or inability to exercise. And I see people with all types of different heart diseases who already have a cardiac diagnosis who need to have cardiac care in order to continue being active and continue doing their sport. When we see athlete patients, it's a little bit different because they're not only trying to live their normal lives, but they want to be able to continue playing their team sport or running or biking at a high level, things like that. And so we look at whether they came in just for a screening visit or are they having symptoms. Um, is there any family history of cardiac problems that might explain what's going on with them as opposed to some of the normal athlete adaptation that we might see from higher levels of exercise? There are a lot of difference in female athletes versus male athletes as well. So a lot of the studies on athletes have focused on the changes that happen in men. So some of that was related to, decades ago, most of the people in organized sports were men, but now that's no longer the case. But even today, very few studies have focused specifically on changes in women or differences between women and men in sports. There are some differences both in the type of remodeling that we see in people doing high levels of sports, but there are also differences in the lifelong effects of exercise on women and men, including types of abnormal rhythms that might happen and also risk of cardiac arrest. This is just a graph showing that the percent of money spent on research on female athletes has not really kept up with the amount of participation of women in sports. So the blue circles in this graph here represent the percent of female participants in sports. Since the Title IX Act ensured that there would be equal funding for women's and men's sports in college, and that they would be treated equally. So over the decades since the 1970s, the participation of women in sports has risen to very close to 50%, which is fantastic. The red line shows research dollars spent, and that has really significantly lagged behind. There has been some increase, which is great, but it has really lagged behind compared to participation of women in sports as well. So that's something that I think really needs to change. Because of that, there are some differences we know that there's some difference in female athlete hearts, but there are some gaps in our understanding. So, for example, in women, there are some changes on the EKG that maybe they're just due to changes in chest anatomy, but there's also a difference between the right side and the left side of the heart in women. In cardiac imaging, there's some different changes that we see. There actually are lesser changes in women's hearts than in men's hearts for the same amount of exercise. We also see a lower amount of cardiac arrests in female athletes, coronary events, and atrial fibrillation. We don't really know exactly why that is, but we know that there may be some relation to hormone differences, some differences in cardiac remodeling, and it used to be thought that it might just be differences in amounts of sports exposure, like that women were playing less sports, but now I think that's no longer the case, so we can't really attribute the changes just to a difference in participation. Some of the sex-based differences in exercise performance include, and women have improved muscular fatigue resistance, meaning that for very long distance endurance events, women do better. We also don't really know why that is. We think that has something to do with hormone changes, that even though the sort of short-term, like sprinters and so on, overall, if you look at people that do short-term high burst levels of activity, men will generally outperform women. But if you look at very long events, and the longer they are, the more likely you are to have women that are outperforming men. So I always thought that was kind of interesting differences in physiology. So for example, these are some examples of ultra endurance athletes in sports, including on the lower left, there is a woman named Jeannie Zapp, who is an amazing swimmer who swam across the English Channel, which is more than 25 miles in frigid cold water. Yasmin Paris finished an event called the Barclays Marathon, which is a 100-mile trail race. And Courtney Dauwalter on the right is another ultra runner who does 100-mile races. And these women all routinely outperform men, not just for their size but can actually outright events that are very, very long can be won by women. So very long swimming events, very long ultra endurance running events. So that's a very interesting difference in physiology of that women are built more for endurance than for high levels of speed. I wanted to tell you a little bit about the type of cardiac remodeling we see with exercise. When we think of different types of sports, the type of sport determines what changes we see in the heart with exercise. So, static or strength exercise, like this bodybuilder here on the left, or the weightlifter here, lifting these humongous weights, um, that type of exercise over long periods of high levels of training usually increases the thickening of the heart wall more than the overall sizes of the chambers. Whereas if you look at marathon runners, like the women on the right who are running the marathon here, that type of dynamic or endurance exercise generally leads to more chamber enlargement of the ventricles rather than heart wall thickening. These are not exact. Sometimes there's some overlap between these two, but it sort of makes sense that the athlete on the left and the athletes on the right are completely different body types that are suited to their sport, that the heart would react differently to different types of exercise. So if we think about the pluses and minuses of this type of remodeling or of lifelong exercise, for the most part, lifelong exercise, even at a high level, is very, very positive. People who are fit generally live longer. They have less heart failure. They have fewer coronary events, generally much healthier. And these are only the cardiac benefits. There also are a lot of additional benefits with better bone density, better balance, better cognitive function as people age in people who maintain a higher level of fitness. Um, there are some downsides, people who, not to regular exercise, but people who are lifelong athletes who are doing many hours per week for years or decades of very extensive endurance events, do end up with more rates of atrial fibrillation, maybe increased rate of needing a pacemaker due to slow heart rates. And there are a lot of unknowns. In the center, we're looking at differences in rates of other types of heart rhythms. Um, there also seems to be an increased rate of coronary calcium buildup, although that doesn't necessarily lead to more heart attacks, but some other factors that might be a result of extreme levels of exercise. Something that's been in the news a lot among athletes, not that has been cardiac arrest. So there have been a couple of very high profile cases of cardiac arrest in athletes from people who are in team sports, such as Bronny James or Damar Hamlin over the last couple of years that have been in the news. But it also happens that you may hear about somebody who died running a marathon or in a triathlon and things like that. And so I just wanted to talk about that a little bit because it's something that people who do sports or in general are, of course, this is a terrible thing when it happens. It's infrequent, but it's tragic and shocking when an athlete collapses because athletes are kind of viewed as the people that are supposed to be the healthiest. So how could it happen to somebody like that? It often gains a lot of media attention if it's in a pro athlete or at a televised event. Um, and a lot of sports cardiology screening efforts are done in an attempt to prevent these or to try to catch people that might have underlying heart disease before something like that happens. There's a lot of controversy about who to screen and when because most of the people are very healthy. And so it's not always an easy answer about what type of screening is most appropriate. Athletes overall are at risk, higher risk of cardiac arrest than non-athletes, but some of that may be due to the amount of exposure that they get. It seems worse than it is in a lot of cases, though, because there's a lot of media attention that may skew. So, a couple of very high-profile cases makes it seem like there are a lot of people who are having this problem, but there also are many, many thousands of people that are not having a problem. So we have to kind of look at that in the context of like how of the population. Um, Cardiac arrest can occur during the sport, but it can also occur at another time, while you're not playing a sport. We think that some of the risk in athletes may be related to bursts of adrenaline with competition or with vigorous exercise, or that it might be that because of the high level of exercise, you're triggering an event in someone who otherwise had an underlying risk, a risk that they might have had even if they were not playing a lot of sports. There also could be higher risk of events due to more frequent exposure to high levels of stress due to very vigorous exercise. We're not really talking about sort of a normal day-to-day exercise that people are, doing um, regular 30 minutes of, moderate exercise. These are people that are competing at a very high level. So the stress on the body is significantly higher. when we think about cardiac arrests in young athletes is different from older athletes. And so athletes over age 35 or 40, most of it is coronary artery disease because that's the most common ways that an adult, an older adult may have a cardiac arrest. Under age 35, it's maybe more likely something that could be inherited or an electrical problem, something like that. One thing that's come up is that we looking at a lot of the data that is available, are women protected from the risks of high levels of exercise? And it seems to be that the answer to that is yes. So compared to males, female athletes have a significantly lower risk of cardiac arrest. They have reduced risk of elevated calcium scores. So some of you may have had calcium scores checked in your heart to see if there's any buildup of cholesterol, things like that, that female athletes seem to have lower rates of that than male athletes. And women in general, not just athletes, have lower rates of high calcium scores than men. There's less scar tissue in the heart and a lower risk of atrial fibrillation as well. Again, like I mentioned before, we don't know completely why this is. We believe that there are some hormone-based changes. Maybe women have, on average, lower blood pressure or lower body size overall that might be contributing to some of these reduced risk factors. We do know that exercise is beneficial, and in some cases, higher levels of exercise may be of greater benefit in women than in men. So this is a little bit of a complicated slide, but if you just look at the section on the right, the women are red and the men are blue, and the bars that you see are with increasing amounts of exercise. So aerobic activity are things like walking, biking, etc., minutes per week. So you can see even up to about 6 hours per week, there's a greater benefit in women. So the red bars here are farther to the left than the blue bars, which represent men. So there's still more benefit in women than there is in men for this amount of exercise. Strength training as well. Women benefit greatly, 2 to 3 sessions per week of strength training. You can see that the red square here with the bars is much farther to the left than the blue one because there's a greater benefit in women for strength training. Up to 2 to 3 times per week. More frequent than that, there actually is less, maybe there's more risk of injury or something like that with doing it too often, but 2 to 3 times per week seems to be the optimal amount. So just to talk about hormones for a little bit, there are many hormonal changes in women's life that we think affect overall heart health, overall exercise-related factors. And there are at least 3 major changes in a woman's life that may affect this, right? So the first one is puberty, of course, where the differential effects of both estrogen and testosterone really take hold as both boys and girls enter and go through puberty. And that's where, if you look at younger children, for example, there's a much lesser difference between girls and boys before they go through puberty, and then things start to separate afterwards. The second point in most, not all, but women who choose to have pregnancies, pregnancy hormones play a significant role in overall cardiac risk. We didn't talk today, but there's some specific pregnancy-associated cardiac risks that can occur. That's a whole other talk for another day, but something to be aware of, and that it can affect the ability to exercise. It affects hormone changes in the heart, and then can lead to other risk factors later. Pregnancy in athletes can affect exercise during, of course, and after pregnancy, and can affect the timeline for someone to be able to return to their sport. Around the time of menopause, of course, is the third major change, and that there are changes in exercise tolerance and cardiovascular risk in the peri and postmenopausal period. And then last but not least, people who take sex hormones for other reasons, for contraception, for hormone replacement, gender-affirming therapy, that affects the balance of hormones in the body as well, and can affect our ability to exercise, our responses to exercise, and our overall cardiac risk. So those are all important ways that hormones can affect our bodies overall. So just to kind of sum this up again, we're looking at the sex-based differences in exercise-induced cardiac remodeling and also cardiac changes in women versus men. There are some changes we see on imaging. So if you've ever had an ultrasound of your heart, if you're very athletic, there might be some changes that we see that are different in women versus men. Coronary calcifications, which can lead to coronary artery disease, there's a lower risk of that happening in women who are athletic compared to men who are athletic. There are some changes on the EKG that can be seen that are a little bit more subtle, but can lead to differences in interpretation. And then over on the lower left, we also talked about a lower risk of atrial fibrillation and a lower risk of cardiac arrest in women versus men athletes as well, athletes and non-athletes as well, for that matter. All right, so we're coming to a close here. I wanted to give you a few take-home messages to think about, and of course, if there are questions, there'll be time for questions afterwards as well. So the first thing is that changes that occur with cardiovascular aging lead to increased risk of heart disease, stroke, and high blood pressure across the board, women and men across the board. However, there are a number of important differences in cardiac changes and normal cardiac function between women and men that we talked about. And for everybody, healthy diet, exercise, and minimizing cardiovascular risk factors will lead to successful cardiac aging. And in terms of exercise, we know that women adapt to exercise differently compared to men. Women have a lower risk of exercise-associated coronary calcifications, fibrosis, which is that microscopic scar tissue I talked about, atrial fibrillation, and cardiac arrest, all lower risk in women than in men of equivalent risk factors. And that equal representation of women in research will improve our understanding of sex-based differences on the effect of exercise in the cardiovascular system. So with that, I wanted to thank you all for paying attention. It was great to be able to speak to you today, and I'm happy to take any questions. My office is in Columbia, Maryland, in Howard County. If you are interested in or have someone who wants a sports cardiology referral, the number is here to call my assistant Karen or our general scheduling number. Our general office number is on the lower right for general appointments, heart failure appointments, et cetera. You know, I work in a pretty big office now. I'm the medical director of our office. We have a nice group of other cardiologists who can help anyone who might need to have an appointment or need to be seen. So thank you very much.
Thank you, Dr. Baruch, for that very informative presentation. We will now begin the Q&A portion of our webinar. Our first question: why are so many more Americans taking statins these days?
That's an excellent question. So statins are a group of medications for treating high cholesterol. One thing I will say about statins, they get a bad rap in the media overall because they do have a fairly low but non-zero rate of having side effects. The reason that so many people are taking statins is because we have learned that even an average amount of cholesterol significantly increases cardiac risk. And so over the last decade or so, the goal cholesterol level that we have to help reduce cardiac risk or prevent heart attacks and stroke has been moved lower and lower because we have found through large research studies that that lowering cholesterol will help reduce risk of heart attack and stroke, especially in someone who has risk factors or who has had one already. We want to get it much lower than average in order to prevent future events. So as a result, many more people are being prescribed statins to help reduce their cardiac risk.
Great. We have a comment and then a question from Mary. Mary says, women's signs of heart attack seem vague to me, less clear than those for men. Is there something more you can say about it?
So that's also an excellent question. And it is challenging because they are more vague in some cases. I think the best thing I can say is that patients who are, or anybody who might be having a heart attack usually has some sense that something is really wrong. Sometimes people call it an impending sense of doom or something else that seems not right, or if they feel really sick out of the proportion to the symptoms that they're having. The majority of women will still have some of the classic symptoms of chest pain that goes to the left side, things like that. But I tell people not to ignore symptoms that seem really out of place or severe. You know, if you have a little indigestion, your chest feels a little funny, that's probably just indigestion. But if you have pretty bad pressure, even if it's in your abdomen and you're in a cold, clammy sweat, things like that, that's a time to take it seriously. So that doesn't work 100% of the time, but if you have a general sense that something is really wrong and you have even some of those vague symptoms, that would be a time to take it seriously. And if you have any questions about symptoms that are less severe, that's a good time to talk to your doctor about whether it might at least um, be helpful to have a cardiac evaluation to make sure that it's not something serious.
Dr. Brooke, we have a question regarding medication. Is coronary calcification always treated with statins?
Um, Most of the time it is because it's an indication that there is underlying coronary disease, even if someone has not had a heart attack or a stroke yet. Coronary calcification is diagnosed by something called by CAC score. The coronary calcification score is diagnosed by a type of CAT scan, an imaging study, not a blood test. And so when we discover that, many times we're doing that for risk stratification. So we're trying to discover, does somebody have additional risk? So we know that from many studies that people with a high coronary calcium score have a higher risk of heart attack or stroke. And most of the time it's related to high cholesterol. So again, in that situation, someone who has an average cholesterol but a high level of coronary calcification, we know that person has high risk. The best way we know as of right now to reduce that risk is to prescribe medications to lower the cholesterol. Not everyone has to take a statin though, and there are a percentage of people that don't tolerate statins. So things like muscle pain and things like that are not common, but there's somewhat common side effects. There are now a lot of new categories of medications to lower cholesterol that are not statins. So statins are still kind of the tried and true medications, but if someone doesn't tolerate it now, we have many other options of non-statin medications that lower cardiac risk as well. And so I encourage people to work with their doctors if they are prescribed a statin, but are not feeling well on it, to go back to the doctor and tell them they're not feeling well, to either try a different statin or to try one of the newer medications to get cholesterol down. I think that, like I said earlier, statins kind of get a bad rap in the media, but they're very good at what they do for reducing cardiac risk. And the majority of people don't get side effects. The percentage of people that do, we have other options now to give people to reduce their risk if they don't tolerate a statin with different medications.
Our next question is regarding medical care and screenings. Are yearly cardiological checkups recommended for menopausal women?
So that depends on your overall risk. I don't think that every postmenopausal woman who has absolutely no cardiac risk factors and no cardiac symptoms need to see a cardiologist every year. I do encourage people to come for like a preventive cardiology visit if they have concerns, any risk factors, any prior disease, of course, things like that. I think that depending on the person's risk status, they might just need a one-time consult and then to be able to work with their primary care doctor to maintain a low risk level. But if someone has risk factors or symptoms, then I think that they should have cardiac follow-up.
Great. And then our next question is from Carol. Carol asks, is it good to take COQ10 when taking statins?
Oh, that's an interesting question. So many people do that. The scientific studies have not really proven conclusively that that reduces, well, just for other people who may not know what CoQ10 is, or coenzyme Q10, is something that there's some cardiac benefit to taking it. It's a supplement. It is thought by some people to reduce the side effects of statins. So there have been some studies that have not really conclusively proven that to be the case. However, it's pretty harmless if you take it and you don't really need it. It's not likely to cause any downside. So I don't prescribe it for my patients who are on statins, but if somebody wants to take it or they've tried it and it seems to help, then I encourage them to keep taking it.
Is there any role for triglycerides in increasing the risk of a heart attack, or is cholesterol the main culprit?
That's also an excellent question. So there is a role for triglycerides. The medications so I would say the LDL, so the lipid panel consists of several different components. So There's the total cholesterol, and that's calculated from the LDL, which is what we call the bad cholesterol, HDL, which is the good cholesterol, and triglycerides. Triglycerides are the ones that are most responsive to diet, and so there are medications specifically for triglycerides, but they don't really help your cardiac benefit long term as much as statins or reducing the LDL. So we do pay attention to triglycerides, but we don't commonly put people on medications only specifically for triglycerides any longer, because even though those medicines lower triglycerides, they don't reduce the risk of heart attack as much as the statins do. But we do pay attention to that, and we usually recommend increased physical activity, changes in diet, and also for people with diabetes will very commonly have high triglycerides. So getting better control of diabetes can bring triglycerides down as well. So they are important, in addition to the LDL cholesterol, which is what we call the bad cholesterol.
See, Jane, you have your hand up. Unfortunately, during webinars, we do not have the capability to answer live questions from the audience. So please, if you have a question, please type it either in the Q&A box located at the bottom of the screen or in the chat box. Thank you. Our next question is, if there are odd heartbeats after sedentary work years, will exercise help that?
Can you repeat if there are odd
heartbeats after sedentary work years? Like if someone has been working from a sedentary job or position, or they're functioning primarily in a sedentary capacity, will exercise help that? Like if it's been a long-term issue.
It can. I think that somebody who's having extra heartbeats, or somebody who's having a lot of extra heartbeats probably needs to get a cardiac evaluation before determining what the best way to treat that is, or if it needs separate treatment. So certainly, if someone has had many years of a sedentary job, increasing exercise either while they're still working outside of work hours or after they've retired will help cardiovascular health overall. The issue with extra heartbeats are fairly common, but until we know what's causing them, then we usually would do an evaluation to see what's causing it before recommending a specific treatment. So exercise isn't necessarily a specific treatment for that as it is, but if it turns out to be just related to deconditioning or something like that, then exercise would help.
Our next question comes from Barbara. Is high HDL still protective?
Yes, high HDL is still protective, but we previously, so some of you may have heard that previously we would look at the ratio of HDL to LDL, or if the HDL was high, we would sort of ignore the LDL. We don't really do that anymore. So high HDL is still a benefit. That's what we kind of nicknamed the good cholesterol. And it is protective, but that doesn't mean we can ignore the bad cholesterol. So we still need to treat bad cholesterol, even in somebody who has high HDL, but there is still a protective effect of high HDL.
Our next question comes from Jack. Why is a calcium score test? Are some numbers low and some high?
The calcium score test usually will give you the amount of calcium that is in each of the 3 coronary arteries separately, and then give you a score of the whole score added together. So the distribution of calcium in the arteries is usually not even. We don't really know why that is, but sometimes there'll be a lot of calcium in one artery and very little or none in a different artery. The calcium score, the distribution of the calcium in the arteries is less important than the total score for this, because it doesn't really take a picture of the coronary arteries. Even if there's more calcium in one artery, that doesn't mean that the blockage is necessarily worse there. It's more of like a total burden of calcium that is what best determines the risk. If there's a question about a significant blockage, then you might get a slightly more advanced CT scan of your coronary arteries called a coronary CTA. That involves a contrast injection, but that does actually tell us where the blockages actually are. But the difference, if you get a calcium score done and you see several numbers, and then the bottom one is the total, each one is sort of like the amount of calcium that is added up from each of the three coronary arteries separately, and then the last number is them all added together.
The previous audience member that had a question about the sedentary work, years after a long period of time, had a follow-up comment. And that person says, I've been told abnormal beats are harmless but annoying, no medication needed. So I'm taking this as that was the diagnosis from the physician.
Yeah, so those are common. So those are the kind of common extra beats that we see. They actually are fairly common in women around the time of menopause, also so during menopause or during any time of hormonal changes. Those types of beats, the beats that we generally call harmless but annoying, are can be affected by things like lifestyle factors. Changes in lifestyle factors can actually help reduce those over time. So things like getting enough sleep will help reduce them. Having a lower stress levels, reducing alcohol and caffeine, those types of things, regular physical activity, all those things will generally reduce those types of extra heartbeats. Once it's determined that it's not a dangerous rhythm problem, things like that, we usually recommend those lifestyle type changes to help get them under control. And then in somebody who tends to have those, they still can flare up at times of stress, for example, sometimes even good stress. If you're going on a vacation or a trip, something like that, it can stir them up. But then once you're back and things settle back down again, they should settle back down to baseline. But some of those other modifications in your overall lifestyle can help reduce the amount of annoying factor that they're producing.
This is for Jane. Jane, I'm not sure if I interpret your question correctly, but please feel free to type in the chat if I get anything wrong. But Jane says that she has coronary heart problem and low thyroid, a problem sweating, and she also has a small pain in her left side. I'm assuming she's maybe asking for any tips or based on her conditions.
Say the first part, coronary.
Sure. Coronary heart problem, low thyroid, problem sweating, and also a small pain on her left side.
Okay. I guess I'm not sure what the question is. I think that might be too specific of a medical description for me to give an adequate answer in a webinar. I would encourage you to sort of see your doctor or see your cardiologist. Or if you don't have a cardiologist, to ask for a referral to a cardiologist to have that further evaluated. There are a number of different types of things that those symptoms could be related to. I would like to make a comment about thyroid disease, though. Thyroid disease can often cause palpitations, like feeling like your heart's out of rhythm, or discomfort that sounds like cardiac symptoms. Sweating, those types of things are very common in people with thyroid disease. So I think that that's something that we see quite a bit.
Dr. Baruch, we have about 2 minutes remaining and 3 questions. So let's see if we can get these last three answered pretty
Okay.
quickly. The first of the three is sleep apnea a risk factor for heart disease?
Oh, that is a definite yes. For people with sleep apnea, it's extremely important to get it properly diagnosed and properly treated because it does significantly increase risk of many types of heart disease.
How has COVID affected cardiac risk?
COVID affects cardiac risk in a lot of ways as well. So we know that people who have had COVID, who either have or have had COVID recently, are at increased cardiac risk. People can have heart attacks related to COVID. Another sort of related issue, people can have blood clots related to COVID, either in the coronary arteries or the pulmonary arteries that can be very serious. We know that cardiac events are more common for a number of months after someone has had COVID as well. So if you're eligible for vaccines, we recommend COVID vaccines to help prevent some of those downstream complications of COVID also.
Thank you, doctor. And our last question comes from Julie. Going back to coronary calcification, if one does not have any blockage from a CT coronary scan, but a high calcium score and is on statins, exercising, etc., are any other strategies recommended, and can the calcium score be reduced?
So what you just listed are the best ways to reduce cardiac risk if you have a high calcium score. You can ask your doctor whether an aspirin a day, a baby aspirin a day, is appropriate for someone with a calcium score that's over 100. Sometimes they will recommend that if there's not too much additional risk. The calcium can never be reduced because it's already sort of trapped in the walls, but it can be stabilized by the things that you already mentioned: exercise, statins, aspirin. And so it can become inert that way and not cause problems, even though it can't be removed.
Thank you, Dr. Baruch, for answering those last three questions. We are now going to transition to, give me one moment, as we prepare to wrap up here. Just want to give some final instructions to the audience. Ladies and gentlemen, this concludes the question and answer session and today's webinar. On behalf of the Community Health and Wellness team at Suburban Hospital, we sincerely thank you for joining us and extend our deepest gratitude to Dr. Baruch for sharing her expertise today and answering these thoughtful questions. We hope this discussion helps you make more informed choices regarding your health. As a reminder, please take a few moments to complete the survey that will appear at the end of the webinar. Your feedback is greatly appreciated and helps us improve future programs. Thank you again, and have a wonderful rest of your afternoon.